All right. The next few slides, we are going to be discussing exactly how we create bone and dissolve bone, actually, as well as our bones are not static. We are constantly creating and dissolving bone to adjust for both structural needs as well as blood calcium needs. So there are a variety of hormones that are going to be playing a role in this, and this is what we're going to cover. All right. First and foremost, we need to discuss in order to create bone, we need to have something called mineral deposition. Mineral deposition is when we remove calcium, phosphorus, and other minerals and ions from the blood and deposit it into the bone tissue. This is what is going to harden the bone tissue. This is going to involve osteoblasts. Osteoblasts are our bone cells that are going to be creating bone. They produce collagen fibers that spiral around them, trapping these minerals. These minerals, when they're trapped on these collagen fibers, are going to create a hardened matrix, and this is what we know as bone. These fibers are going to spiral in alternating directions, so they don't all go clockwise. Some go clockwise, some go counterclockwise. This alternating spiraling direction versus all in one direction is part of what gives bone its strength. If it was all in one direction, we would only need to have a force in that same direction to cause the bone to break. Instead, because we have them going in both directions, we're going to have to use a whole lot more force to break these bonds. In order for us to put these ions on these crystals, we're going to have a positive feedback mechanism in place, but we're also going to have to reach a solubility level. What does this mean? Picture a pot of water on a stove with salt in it. And you put a piece of string in it, or sugar. Sugar works too. You put a piece of string in it, and then you turn off the heat. And you let it start to cool. You can also keep the heat on, keeping it boiling. It works faster that way. Either direction, though, works. You let the water evaporate. And the salt comes out of solution and clings to the string. It starts to crystallize. This is what this line right here, this is what that is referring to. Once we start to get this salt, or if we're talking about bones, calcium, magnesium, phosphorus, once they start to come out of solution, they're just going to feed. So if we have calcium coming out of solution, that calcium is going to cause more calcium to stick, and that's going to cause more calcium to stick, that's going to cause more calcium stick, and it's going to feed into itself. It's going to just cause more and more to happen until something causes it to cut off. That is a positive feedback loop. It feeds into itself. Now, in order to get that calcium back out of the bone, back into the bloodstream so that it can be utilized by our muscles for muscle contraction, or our nerves for neurotransmitter release, or there's another use for calcium that I'm blanking on. In order to get it out of bones, we are going to have to utilize our osteoclasts. Osteoclasts are the opposite end of the spectrum from our osteoblasts. Osteoclasts are typically known as our bone destroying cells because they are going to create a acidic environment. They're going to have hydrogen pumps that are going to secrete hydrogen ions into the space around them, and that is going to create a decrease in the pH level. Specifically, this is going to cause chloride ions, which have a negative charge, to be attracted to the positively charged hydrogen ions, creating hydrochloric acid. So we're going to get a pH closer to 4. Once that pH gets close to 4, those bone minerals, calcium, phosphorus, magnesium, that were attached to the collagen fibers are going to detach and be dissolved back into the interstitial fluid. To aid in this dissolving process, an enzyme called acid phosphatase is actually going to digest and break down those collagen fibers, allowing for easier reintroduction into a solution. Now, for my dental hygienists, what does that mean, or what's going on, I should say, when we're doing braces? So dental braces, in a tiny little nutshell, I am simplifying this process a lot, they're going to reposition the teeth in the jaw. In order to do that, the braces create a greater pressure on one side of the tooth versus the other side of the tooth, in whichever direction we want to shift that particular tooth. What this does, that increased pressure, is actually going to stimulate the osteoclast. So it's going to stimulate this production of hydrochloric acid to dissolve the bone on that side of the tooth to relieve the pressure, causing the bone to shift over. The decreased pressure on the other side of the tooth is actually going to stimulate our osteoblasts to create those collagen fibers and start to stick calcium, phosphorus, and magnesium to them to create new bone. That new bone is going to push the tooth back into the area that's now free of tooth, or free of bone, shifting the tooth over. That is a simplified version of what is happening, but it is the basics of what is happening when you have braces. All right. Phosphorus, otherwise known as phosphate, is used in a wide variety of things in our body. So having a large supply and store of it is really necessary in order for proper human organism functioning. Just an example of what it's used in our DNA. If I don't have phosphorus, I can't make new DNA. If I don't have phosphorus, I can't make new RNA, which means I can't take my DNA, I can't read it, and then I can't make new protein chains. I can't make new muscles. I can't make new cells. I can't make new bone. I can't do anything. Phosphorus is also utilized in the creation of ATP. ATP is our energy molecule, and without ATP, we're not going to have muscle contractions. We're not going to have nerve signal transmission. We're not going to have digestion occurring. We're going to grind to a halt. So if we don't have phosphorus, we don't have energy, we don't do anything. Phosphorus is also utilized in the creation of phospholipids. Remember from our cell chapter, phospholipids create the cell membrane. So if I don't have phosphorus, I can't make a cell membrane, which means I can't make cells. And then phosphorus is also utilized in what we refer to as acid-base buffers. We will talk more about those with the urinary system, but acid-base buffers are going to be important to maintain proper pH balances in our various fluids in our body. So phosphorus is really, really important. Calcium, as I mentioned, is needed for the release of neurotransmitters. So it's important for nerve signal communication. We're going to discuss with our muscles, it's highly important for muscle contraction. If I do not have enough calcium, my muscles do not contract. And if you're just thinking, oh, that means I can't do a bicep curl, this is also true. But if my muscles can't contract, I also cannot digest my food. I cannot move it from my mouth down to the exit. If I do not have calcium, I cannot contract my heart. So my heart doesn't beat. Calcium is also going to be involved in blood clotting. So if I don't have enough calcium, I'm not going to be able to stop a bleed. On the flip side, if I have too much calcium in my bloodstream, then I can create blood clots where I don't actually want or need them. So there is a fine balance there. And then calcium is also involved in exocytosis, which, if you remember from our active transport chapter, is the exporting of things from the cell. So if calcium and phosphorus are really, really important. Now, we are picking on primarily calcium and phosphorus. However, magnesium and vitamin D are also really important here. But if I'm looking for an ideal operating amount of calcium, I'm looking to have a blood plasma concentration of 9.2 to 10.4 milligrams per deciliter. 45%, so almost half of that, is going to be free-floating calcium ions. These calcium ions are going to be very usable, so they can readily be used by muscles, nerves, clots, whatever needs to use them. The other 55% is going to be bound to blood plasma proteins and have to be removed from those proteins in order to be used. Phosphorus, we're looking for a concentration of about 3.5 to 4 milligrams per deciliter, and it is also going to hang out in two different forms, HPO4 minus 2 and H2PO4 minus. Minus 2, and the minus is simply referring to the charge, so HPO4 and H2PO4, essentially. So these are going to have negative charges. As we mentioned, we want a proper amount. Phosphorus, we've actually noted that changes in phosphorus concentration don't seem to have much of an effect despite how critical it is to our proper function. We seem to be able to regulate it and adapt for it pretty well. Calcium, on the other hand, not so much. If I have a condition called hypocalcemia, from medical terminology, you hopefully remember that that means a blood condition of low calcium. If I have hypocalcemia, we're going to be looking at an excessive excitability of the nervous system, meaning the nervous system is going to overfire. This is going to lead to muscle spasms. This is going to lead to tremors. This is going to lead to tetany, or seizing of the muscles, and you're unable to contract the muscle. Laryngospasms are also one of these possible muscle spasms. So your voice box can spasm if you have low blood calcium. And when your voice box spasms and spasms shut and you're unable to open it, this can lead to suffocation and death. So blood calcium, very important. One of the recommendations I used to give when I was a active practitioner was when my patients would complain of Charlie horses seizing muscles, I would tell them to A, drink more water, but B, take a calcium supplement, since these tremors and muscle spasms can be due to low blood calcium. If it's not due to low blood calcium, the calcium supplement isn't going to do you any harm in a normal, healthy individual. All right, why? Why does calcium cause this nervous system firing? Calcium normally binds to the cell surface, contributing to resting membrane potential. With less calcium, the sodium channels, which we're going to discuss when we get to the nervous system towards the end of the semester, the sodium channels open up far easier, which means we have an action potential that is created far easier. So we get signals occurring when we normally wouldn't, essentially. If I have hypercalcemia, on the other hand, excessive calcium in the bloodstream, we're going to have excessive binding to the nerve cell surface. This is going to cause sodium channels to be less likely to open, which means we're going to have a depressed nervous system. What does that look like? We're going to okay, I need to do a bicep curl, and have a very delayed response if we're able to curl it at all. We may feel, quote unquote, weak. not because our muscles aren't strong enough, but because they're not getting the signal they need to use all of the muscle cells that we need to do that particular activity. So we store calcium in our bones to help prevent these two conditions from happening. If I have too much calcium, I store it in the bone. If I have too little, I release it from the bone. And that process is controlled by three things: calcitriol, calcitonin, and PTH. These are three hormones that we're going to talk about. By the way, this picture is actually showing you a carpopedal spasm, which can occur due to that hypocalcemia. Calcitriol. Now, with calcitriol, we have to go through a variety of steps. First and foremost, what is it? It is activated vitamin D, which means I need to have a healthy functioning kidney, I need to have a healthy functioning liver, and I need skin cells that are exposed to UV light in moderation. So UV radiation that penetrates into our skin, those epidermal keratinocytes, is going to get converted into a cholesterol derivative. So I also need a proper amount of cholesterol. I know media and the healthcare system has kind of demonized cholesterol. Cholesterol's bad, but cholesterol is critical for the healthy functioning of our cell membranes, and most of our hormones are based on cholesterol molecules. Case in point, vitamin D, which is necessary for healthy bones. So I need the proper amount of cholesterol available, and it is going to get converted by UV rays into something called 7-dehydrocholesterol. This is essentially a pre-vitamin D3. It will then get converted into cholecalciferol D3. This is going to travel to the liver. The liver is going to add a hydroxyl group, and that's going to convert our cholecalciferol to calcidiol. That is then going to go to the kidney, where we're going to add on another hydroxyl group to finally convert it into calcitriol. Calcitriol is going to act like a hormone, meaning it is going to be a blood-borne messenger, and it is going to act upon the intestines, specifically the small intestines, and it's going to stimulate the absorption of calcium, phosphate, and magnesium from your GI tract. So, if I'm not getting enough sun, and there is such a thing as too much sun, as we talked about with the integumentary system, but if I'm not getting enough sun, I'm not creating enough vitamin D, which means I'm not necessarily going to be able to absorb all of the calcium I take in through my diet. We do have not calcium supplements, we do have those, but we have vitamin D supplements. Depending on the form of the vitamin D supplement that you take, you may or may not be getting any benefit from it. Specifically, you want to take this form of vitamin D3, cholecalciferol. Cholecalciferol can be absorbed from the small intestine, converted into calcidiol, and then calcitriol, where it can then be used. If I take this form has to have UV radiation. So if I'm taking a vitamin D supplement but not going outside, it does me no good. You can also take vitamin D in this form as well, but this is the one that's typically found on the market. So if you're looking at a vitamin D supplement, you want to look for this right here. All right. So Calcitriol is going to help us absorb calcium and phosphate and magnesium into our bloodstream from our GI tract. Excuse me. It's also going to kind of trigger the kidneys to not get rid of as much calcium. So this will make a little bit more sense when we go over the urinary system. But if my kidneys are constantly balancing the ions in my body, and one of the ions it balances is calcium. So if calcium is pushed out of the bloodstream into the nephron, the functional unit of the kidney, calcitriol is going to prompt the kidney to put more of that calcium back into the bloodstream versus excreting it through your urine. We will go over that in far more detail, though, with the urinary system. Calcitriol is also going to promote osteoclast activity. So it's going to trigger those osteoclasts to dissolve collagen, create that pH, that acidic pH, and put calcium back into the bloodstream. Now, there is a condition called rickets in children, and that same condition is called osteomalacia in adults. Why it has two different names, depending upon if it's children or adults, I do not know. But just be aware, it is the same condition, it just has two different names. What is rickets? Rickets is abnormal softness of the bones due to low vitamin D. This image right here is actually diagramming the steps mentioned in the previous slide. Calcitonin. Calcitonin is secreted by C cells. C cells are found in the thyroid gland, and they will secrete calcitonin when blood calcium concentration is too high. What it's going to do, it's going to reduce that osteoclastic activity by as much as 70% within 15 minutes. This is very fast acting. Normally, we're looking 30 minutes to a couple of hours. Calcitonin will work within 15 minutes. So it will reduce the dissolving of the collagen fibers, the dissolving of the calcium back into the bloodstream by up to 70% within 15 minutes. And in that same time frame, it will trigger the osteoblasts to make more collagen fiber and pull more calcium out of the bloodstream. So it's going to diminish one and increase the other to pull calcium out of the bloodstream to lower that blood calcium level. Calcitonin, what we have discovered is that in children, it's super, super important. Calcitonin deficiency in children has huge impacts, but we haven't seen that same impact in adults, and we're not sure why. At least when the textbook was published and the last time I looked at the research, which admittedly I haven't looked into this in the past couple of years. So this could have changed. This is also a really good time to note that your textbook is usually going to be about 10 to 20 years behind the research. Research is constantly changing and adding new information, and textbooks just can't keep up. So if you have seen research, not just hearsay, so-and-so said, or I read in an article from CNN or Fox that, this thing came out, look for the research paper, but if this may have changed. But as of my information right now, we do not know why calcitonin plays such a critical role in children but not adults. Why is this important? We're pretty sure that calcitonin could be used to help minimize bone loss in osteoporotic patients. But if calcitonin isn't as effective in adults, this isn't as effective treatment protocol for our osteoporotic patients. So this is a line of research that we are going into. Like I said, I haven't seen anything, but that doesn't mean something hasn't come out of it. Parathyroid hormone is secreted by the parathyroid glands, which are located on the backside of your thyroid gland. And parathyroid hormone is going to be released when your calcium blood level is too low. So it's going to be released at about the same time as the calcitriol is created. Only it's going to work a little differently. Parathyroid hormone is going to bind to our osteoblasts, causing them to create a substance called osteoclast stimulating factor. This is going to stimulate osteoclast multiplication and activity. Remember, osteoclasts release calcium into the bloodstream. So by binding to osteoblasts with parathyroid hormone, we can create more osteoclasts and the osteoclast activity. The other thing is this is going to promote that calcitriol synthesis in the kidneys. So it's going to promote the creation of the other hormone that is going to impact blood calcium levels. It's also going to be a promoter of calcium reabsorption. So taking calcium that is in the nephron and putting it back into the bloodstream. By binding to the osteoblasts, it's also going to inhibit the creation of the collagen fibers and therefore inhibit the removal of calcium from the bloodstream. One thing that we have noticed is if we inject or artificially cause low levels of PTH in the bloodstream, we can actively promote bone deposition. So depositing calcium into the bone and creating new bone. This is a line of research with our osteoporosis patients and drug treatments. There are some problems with it though. Specifically, what we have noticed is that sometimes what your body does is instead of taking the calcium from the bloodstream, it will take it from another bone. So strengthen one bone, decrease a different bone. So there are problems. All that being said, if we take these three things and our ions to maintain our blood calcium, this is a negative feedback loop. Calcium levels go up, triggers the release of calcitonin. This is going to cause blood levels to go down. If they go too far, this is going to trigger the release of parathyroid hormone and calcitriol, causing blood levels to go back up. And it's just going to wave back and forth. Okay, but what about estrogen, testosterone, and human growth hormone? So, sex hormones, estrogen, progesterone, testosterone, these actually inhibit osteoclastic activity and promote osteoblastic activity. So they're going to inhibit the removal of bone and promote the creation of bone. This is part of the reason why we believe that most women develop osteoporosis after menopause. Our systems are constantly yo-yoing estrogen, progesterone, depositing bone, creating bone, and then we have a sudden steep drop-off with no rise. Males also have a drop-off in their testosterone as they get older, but it's not nearly as drastic. So they don't get this dramatic effect. There's also some other things involved with their muscle mass, because the more muscle mass you have, the stronger your bones are going to be to offset the pull. We'll get into that in the muscular system. So this is some of where our theory on hormones comes into play with bone and osteoporosis specifically. Now, human growth hormone, on the other hand, works a little differently. Human growth hormone is going to work opposite your sex hormones and is going to inhibit osteoblasts and actually promote osteoclastic activity. So high human growth hormone is going to actively promote the dissolving of bone. This particular slide in the PowerPoint is just reiterating why this calcium level is so important and why we need to balance it. Just a reminder, it's important for nerve signal transmission, specifically the release of neurotransmitters. It is important for muscle contractions. It's important for blood clotting, cell division, secretion by glands, and nerve cells. Lots and lots of things. This slide is verbalizing that diagram I had earlier of that negative feedback loop. Rising blood calcium levels trigger the thyroid to release calcitonin, which stimulates calcium salts to be deposited in bone, stimulates osteoblastic activity. This is going to cause the blood calcium to fall till it falls so low that it triggers the parathyroid glands to release PTH. PTH is then going to stimulate our osteoclasts to degrade bone, releasing calcium back into the blood and inhibiting osteoblasts, preventing them from binding bone or calcium into bone. And again, this is demonstrating that negative feedback loop. And this is the number that we're trying to maintain. All right, so that's the end of our hormonal control. We're going to continue this conversation, though, talking about how we actually create bone, for instance, when we're going through a growth spurt. So that will be the next video.